Jane, thank you so much for asking me to speak anyway. I appreciate it. So yeah, today it's not so much about TickerFit, just more about, I suppose, what I've learned through working and building this sort of technology and trying to get it into the healthcare system and sort of what's there already. Just to give you a bit of background, I suppose, about myself. So I left school, I was big into hockey, so I never got into my first choice, which was physio, when I was leaving school. So I did an aptitude test and did really well in spatial relations. So I was told I'd be really good at engineering, but I lasted 3 months in engineering. So I then went on and did media production in DIT, and then fell in love with this man, Garth Brooks. So many of you will know all the debacle from 2 years ago, but fell madly in love with Garth Brooks, didn't even know him, but then decided to do a sound engineering so that I could move to Nashville and potentially marry him. So moved to Nashville. Lived in Nashville for 7 years. I worked in the music industry for about 4 years, and then lucky enough went back and studied exercise science over there. After that, came home and went and studied physio in RCSI, and then went to work in Beaumont Hospital. From Beaumont, had the idea for TickerFit, and now I've since left Beaumont, now working in TickerFit. So I think many people would think, like my mother, that I've had a very random and I don't stick at anything. But somehow it has all come together, and for different reasons it's all connected. You can ask me later about Beaumont and Nashville and how they connect. So just before I start, I suppose at the moment I'm based in London, working with Telefonica and one of the big pharma companies over there. And luckily enough, this is just before everything else, I got this, where is it actually? I've lost it. Anyway, there it is. So they gave me this to bring over to show everyone, and it's a really first of its kind. Now I don't have one for everyone in the audience, but essentially in this box is a pill, and it is a marvel of modern medicine. It regulates gene transcription throughout your body, helping prevent heart disease, stroke, diabetes, obesity, and certain types of cancer. And if you take this pill, you'll feel younger, and you'll actually test younger according to numerous physiological measurements. So it's pretty impressive. Jane, yeah, I have a police escort waiting for me outside. But as we know, this pill unfortunately does not exist, and actually it's just a box from the hotel. But essentially, the treatment does, and the treatment is exercise. And we know that exercise has all these amazing benefits that there's no point in me going on about the research. We all know how beneficial physical activity and exercise is. So this is a famous quote from American College of Sports Medicine, and it's really, if all the benefits of exercise were distilled into a pill, would it not be the most prescribed pill of all time? And I think pretty much we know everyone would want this magic pill if it did exist. So I suppose for some people who've been here before, they might have seen this video, but I think it's a really, really important video just to show, I suppose, the state of the nation in terms of physical activity, not only here, but this one is from the States, and just to give you an idea of really how bad it is. Oh, let's hope it works.
This already late.
Anybody out there?
Do you have a phone?
No. Sorry. Somebody! Hello? There are 2 people stuck on an escalator and we need help. Now, would somebody please do something?
So you get the point. So physical activity, I suppose, as our lifestyles have progressed and as modern technologies taken over, we're less likely to be as physically active as we once were, and there's lots of studies to show that. So luckily our government has taken it seriously, and the Healthy Ireland framework came out, I think, the end of 2014. And I suppose the first thing on the Healthy Ireland framework was really to look at physical activity, and that was kind of the first port of call to try and improve physical activity in our country. So we know there was a national survey done, 32% of people were sufficiently active, and that's from a self-reported questionnaire, which I have my doubts about, but I think it's a good baseline to go on. And over the next lifetime and the lifetime of Healthy Ireland and the framework of Healthy Ireland, it's looking to improve that by 1% across all life stages of the population, so children, adults, older adults. So how are we going to do that? So I suppose there's different ways. There's the Toronto Charter of Physical Activity, which was a global call around physical activity, and they recommended like the 7 best investments in physical activity. And I think Healthy Ireland have taken from that and put out 3 sort of thematic areas to focus on to improve the physical activity standards in our country. So one is around public awareness and public education and improving all our knowledge. I'm sure a lot of people saw the one in the UK there about getting women involved in sport, which was a brilliant advert for healthy living. With children, so through our schools, through our environment, so creating better infrastructure and urban areas for people to become more active and stay active. Workplaces, so through workplace wellness schemes, which was big. I know last year they did a lot of work around that. And then through sport and physical activity for all, so everyone can participate. Another implementation area is through other partnerships, so with say the ICGPs and the chartered physios, and through working with the colleges to try and implement and get physical activity levels up, and then through constant monitoring and evaluation. The area I'm interested in is around healthcare and bringing healthcare into the public health system. And that's really where I started. I did research for the Chartered Physios of Ireland around the role of health professionals when it came to physical activity prescription. And I suppose found that we're pretty terrible at it in terms of we don't use it like it is what it is, this magic pill. We don't use it when we could. And there's sort of 2 main barriers as to why that is. Number 1 is time, people just don't have the time. And number 2 is a confidence in their own ability to do that. And especially for patients that have already been diagnosed with a chronic condition. There are a lot of things that do work though, and I suppose through the research that I read around behavioural counselling, and I know Healthy Ireland have plans. They're currently training up a lot of our health professionals. I think I last checked there was 7,500 people already trained up around brief interventions and brief advice. And then through exercise referral, so that's another big area, and it became really popular in the UK back in the 90s, and it sort of really took off and everyone was doing it, but then NICE did a cost effectiveness kind of paper on it to see, and they said they couldn't support it any longer. So, but as such, people had to change, and people have changed. And I know in Wales now it's really, really popular, and it's actually really effective for the patients that are doing it. Except they're treating more the patients that are living with chronic conditions rather than the people that just need to get active when they can do it on their own. Another area that works well is walking. Obviously everyone likes to walk, well some people do, but it's in terms of prescribing physical activity, that's kind of the main form of exercise that people most like to do. And then community groups, a lot of people have seen around the park run, and the Irish Heart Foundation have different walks and things like that. So there's lots of opportunity for people, but it's about, and I think that's where the primary healthcare as a job, because they see a very specific population that aren't always people that we can reach, just through social situations. They're not the people that are going to come to the park run on their own. So I think the primary healthcare has a special job in helping people get active. Another is around self-monitoring. So we know self-monitoring works. Looking back, I suppose, back in the early 20th century, the first kind of self-monitoring devices were like weighing scales, thermometers, and this was around the outbreak of tuberculosis. So people were having to self-monitor at home. From that then came, where people could check their blood glucose levels for, diabetics, heart rate monitors, blood pressure monitors for hypertensive patients, pedometers, and then peak flow meters for people who are living with restrictive airways, so for asthma or people with cystic fibrosis. So lots of we know how I suppose pervasive all these self-monitoring devices are, and I think as we're moving forward, I think physical activity really is at the core of all of that. So really that's where my idea for TickerFit came about, and I suppose through the research for the Irish Chartered Physios, that I wanted a way to support health professionals and make it as easy for them to write a prescription for physical activity as it is to write a prescription for a medication. And so that's really how it works. Essentially, we have a web platform for health professionals, and from that they can enter some very quick and basic information about the patient, which generates a physical activity prescription for that patient. The patient downloads the app, and from the app they have daily targets, goals that they work towards, and that data then, they see their own progress, but it also feeds back to their health professional. By building TickerFit, as we've gone through, we're doing trials in primary care at the moment in 2 primary care clinics, but now we've also looked at physical activity and chronic conditions. So our other focus is cardiac rehab, so we're working with cardiac rehab physios, and they're delivering the technology to their patients. And I suppose we're looking around delivering the education components as well. Obviously, cardiac rehab is a very structured program for patients already, but a big problem is engagement in cardiac rehab. So less than 40% of patients complete cardiac rehab in the States. It's less than 20% of patients. So it's a really low completion rate, and yet the benefits are so great for the patient if they do complete it. So currently working in those areas, and also in oncology. So just to talk a little bit, Jane asked me to talk a little bit just about our trial that's going on at the moment. We're doing an RCT with the Royal College of Surgeons and the Health Innovation Hub, and really just testing the technology, comparing whether a digital intervention versus a traditional intervention, which is better in terms of promoting physical activity, and going through the GPs, so from the clinics. So as I said, we're working with 2 clinics, and I don't know if Liam is here, but essentially, the Smart Move trial was a really brilliant trial that something that I totally believed in. And essentially with Smart Move, it was, patients were logging their information and sending that back to their nurse. What we've done is automated that process, so it's real-time data is going back all the time to the health professional. So there are primary outcomes like qualifying active minutes and change in step count from baseline week. So what we did is we did an objective baseline week where everybody got the app and tracked their activity in an objective, and then we randomized the patients to either the intervention group or the control group. And qualifying active minutes, so we count the complete active time throughout the day and steps throughout the day, but we also look at qualifying time, so 10-minute continuous blocks of activity. So only when people reach that 10-minute block that we give them credit towards their target. So looking, obviously with public health guidelines. So how the trial has worked in terms of, we have patients referred by their GP, and what we've done, we've had 4 clinics where we've had a nurse essentially go through the baseline assessments and for the primary and secondary outcomes. From that, we've inputted the data onto the platform, which has generated the app essentially for that patient, and the patient downloads the app. Everyone is in baseline mode from the very start, so we're tracking all their data from get-go essentially for the first week to try and get an objective measure, and really comparing that to their self-reported. So we got their self-reported during the baseline assessments. And then from that, after the first week, then they're randomized into the intervention or the control group. So we've had our kind of first cohort literally just finish, and now we're sort of working on the second cohort. So we need 80 patients overall. I think we've 47 gone through. So the intervention group, so they have ongoing engagement. Sorry, the slides are in widescreen there, so it looks a bit skewed, but the ongoing engagement with the application, they can obviously view their daily activity, it tracks all their continuous activity, it counts down their target, they have the real-time monitoring of both their active time and their qualifying time, and then the system generates a weekly progress report for each patient about how they're doing, and suggests ways that they can improve for the next week to get closer to that target. The control group, they carry the app as well, but it's blank essentially, so they have no kind of interaction with the app. It's basically just says active monitoring for the whole continuation of the trial. And they also get the Irish Heart Foundation leaflet around exercise, so typically what a patient might get from their GP, so education around exercise. in terms, so I've asked just the guys to pull together just some of the data just in terms of baseline characteristics. So you can see average age is 47. We have more women so far, and I suppose stress that this is just interim data, it's nothing set in stone, but this is just the data that we've got to date. So self-reported, people were saying on average they were active, on average 3 days a week, and 36 minutes on average. That was kind of the self-reported. And I think what actually what the true kind of, what we measured with the objective data was they were active 28 minutes for 2 days a week. So it's quite a big drop in terms of what they think they did versus what they did on that baseline week. So this is just, again, some interim data just to show the orange group are obviously the intervention group, and just the median is sort of the middle bar there. So again, still, very basic data, but just, it's encouraging, I suppose, to see that the intervention group are going up, and the control group drop right off near the end because they weren't getting any engagement from the app. We were just tracking. And another thing to note, so just coming up to the holidays, I think a lot of people dropped off in the control group as well. So again, hopefully we'll have the full data in the next few months, but that's just some interim data to show you. So I suppose now looking at, okay, we've built this technology and now we're looking to bring it into the healthcare system. And I suppose one thing I've learned, is the healthcare system, if you truly want to understand it, you have to try and change it. And so I've mapped out the healthcare system, I thought, for everyone. It's actually quite easy to get in there. And I'll just show you the map that I put together. And that's where we are. So really, really complex, and we found that, especially in public health, that there's lots and lots of different strings and stuff, different motivations and dynamics, not only here, but definitely in the UK and also the US. So we were just in the US for a month as well. So it definitely, there's lots and lots of little pieces pulling. In terms of, I suppose, these challenges coming together, I suppose there are a lot of challenges around integrating mobile health. One is around the clinical utility. So a lot of apps and things like that are not built around public health guidelines. So that's obviously a big concern, and especially if you're bringing that to the doctor and you're just giving them loads of raw data. They're like, I don't really know what to do with this because it's not what I learned, and they can't put it together. Obviously, privacy and security concerns, like in, I suppose, like HIPAA, when you're sharing protected data with, up through the cloud. Validation, so research versus consumer grade. So obviously, with physical activity, we have our research grade accelerometers that are used for research versus the consumer. I suppose a lot of the research has shown that in terms of step count, it's pretty close, and with sleep, but when it comes to total daily energy expenditure, it's quite far off in terms of the differences. But I think as time progresses, that is going to get closer together, and they are going to merge somewhere in the middle. In terms of the EMRs and workflow, so trying to fit into the clinical workflow of health professionals, so not trying to overburden them with more work, because there is that, the more you add and the more input that they have to do, it does add to their workload. And, at the end of the day, they're going to say, like, well, why am I going to change what I'm doing if it's worked, what they believe has worked to date? So it's, changing that status quo that's there. And you want to make it as easy for them and reducing their workload rather than adding to it. I suppose the exercise vital sign is big in Kaiser Permanente. They did some trials, they had it in 11 hospitals where every patient had to be asked around their physical activity level, and from that a conversation was, the hope was, but essentially it was an objective measure, like they would measure their blood pressure. So they had some small but very encouraging results, and I think in Kaiser now they have that in all the systems, where through their Epic system they have to tick off every time they see a patient, so they can't close the file down until they have asked that patient that question. So I think it is encouraging. Now, I suppose looking at the UK system, it's slightly different. So physical activity was brought in as part of the patient or the care plan for patients with hypertension, so with increased blood pressure, and it was brought into their incentive system that, you know, they can tick off essentially around their QOF, their quality and outcomes framework, to say that they did talk to the patient around physical activity. But a lot of the GPs were very upset about this because they felt that it wasn't cost effective. They would lose a lot of money because the time it's spent for them to go through around physical activity, and they didn't believe that it was going to have a positive effect on the patient. So I think that's out the door. I think they brought it in and then they quickly removed it, which is quite sad. And then behaviour change. So obviously a lot of apps don't have behaviour change techniques built into them. And I know Professor Mickey is going to speak after about that. So I'm not going to go too much on that because I'm not an expert. And then key challenges for tech developers. You know, I suppose there's so many wearables out there, and this is not only for tech developers, but definitely for health professionals. You know, there's 400, I think, you know, I didn't count them, obviously, but 400 or so wearables in terms of tracking activity, over 100,000 apps between iOS and Google and Android. So I suppose there's so many devices that people are bringing to the table, and it's just, I suppose, and especially around native apps, building native apps, and it's quite costly if you keep having to change them. So for the tech developers it's a problem, but also for the health professionals integrating into the system. So with more new innovative companies that are coming through, there's a huge cost with trying to integrate with systems that are out there, patient like EMRs and things like that. So it's a huge cost. So it's hard for, I suppose, startups to try and get their tech into the system that's there. And then building clinical relationships. So essentially, you know, that's a big thing. I think we've been quite lucky just because I suppose I have a healthcare background, and we've been able to build those relationships and get pilots and trials going. But I think for a lot of the, you know, companies that don't have a healthcare background, they do have that problem. Lastly, I suppose, just with TickerFit, what we're just trying to do is really use devices, smart devices. We have some wearables integrated with our technology around, you know, supporting the patient and picking up more data to provide context back to their health professional. And I suppose so we're really trying to use the devices for the best outcome for the patient. So I suppose this is just to show you what's probably a lot of people are still using, what their apps or their phone is for. It's so true. I think we all do it. So really, yeah, trying to put these devices to better use. We know, you know, they're here to stay. So it's really trying to use them for the best outcomes. So just go through that. So yeah, thank you so much.